Okay, good morning.
Good morning.
Good morning, sir. It is a really pleasure to have you all on this Sunday. And I must thank Dr. Ashwini and Karthik from the Nephrology and Academic itself who asked to deliver this lecture about the CRRT monitoring and troubleshoot. So you have learned from Dr. Anand about what are the indications of CRRT and what are the prescription of CRRT, obviously, and you know about the how to start a CRRT machine now. And your consultant is having good faith on you that yes, CRRT can be possible in your institution. And however, it is very essential to learn the monitoring aspect of the CRRT. I'm talking about the machine monitoring, not the patient monitoring at this moment, since it is not in the scope of the topic itself. I will talk morely on the CRRT monitoring itself. And in the CRRT monitoring, what is essential for us is to learn the CRRT machine itself. This CRRT machine is a very complex machine. However, it is an interactive machine. And also it gives you feedback. Whenever you do something in the machine, it will try to give you information about how to troubleshoot if you have any difficulties. So that way, the CRRT machine is apart from the normal hemodialysis machine where you can bypass it, but CRRT machine will give you information on the screen that how to troubleshoot. So you have to learn about the monitoring aspect. What are the alarms? What are the alerts which you will be finding over there? And to minimize your trouble, basically, since always you might not be available or the technicians will not be available at the site 24/7, but you should see that whether the CRRT machine is functioning properly or not. And if you can minimize the alarms and the alerts, then probably you are in peace and everybody is in peace. Okay. So starting with this is my topic outline. I'll go through the introduction part of CRRT, basically the machine itself. Then I'll go through what are the circuit and the sensor alarms which are there in brief, very small summary. What I'll be emphasizing more is on measured pressures and calculated pressures, which you need to know before setting up the parameters. Then what are the pressure alarms which you will be encountering during your CRRT? And there is always a question and debate whether it is a clotted filter or it is a clogged filter. So that thing will take it out in our mind through this discourse itself, that whether the filter is clotted or it is clogged. Then most important of our conversation will be on the filtration fraction and its importance, why filtration fraction is needed, whether can be calculated or it can be automatically calculated by the machine itself. Then the troubleshooting various alarms. And lastly, it will be a take-home message for it. So now you have learned about the acute kidney injury or any renal failure in the critical care unit where multiple vasopressures are there. The patient is hemodynamically unstable. So the best modality or one of the best modality which we can offer at that point of time will be the CRRT if the machine is available. So CRRT is a process where we utilize the extracorporeal circuit, and it is a very slow process which tries to achieve a physiological milieu by the process of both diffusive clearance and convective clearance of the solute. Besides that, it has got other properties like managing the electrolyte and base acid-base balance. And also, if there are any toxins inside like the endotoxins or kind of thing. You can try to remove that by attaching a filter, or also cytokines can be removed through the CRRT in a mild to moderate amount. What is needed to know is, since it is a slow circuit, anticoagulation is needed, and that is either by heparin or citrate. However, in spite of that also, the clotting of the filter happens quite often. So when there is a failure of CRRT, we call it as artificial kidney failure, and that happens more often with the circuit clotting. And whenever there is a circuit clotting or the ineffective delivery of CRRT by any means, you are basically adversely, the patient will be adversely affected and the outcome will be poor. So you want to give an adequate amount of CRRT or the clearance of the solutes as well as the renal replacement therapy without any failure of the circuit itself. And this circuit downtime contributes quite significantly in inadequate therapy, avoidable blood loss, increased costs, and typically waste of manpower, which is dedicated for the CRRT. Hence, we need to know what is the machine and what are the alarms and the alerts which are required to be known to us so that effectively we can deliver the CRRT. So if you see, it is a just simple diagrammatic picture of the CRRT itself. Although you must have seen the machine by yourself, it is a complex scenario, but I wanted to just, few of them might be just initially starting the dialysis curriculum itself, where it will be difficult to learn, but it is a simplistic what I can found in the picture itself. So what you need to know is, what are the sensors which are placed? It is a very complex machine with a different kind of sensor for the safety mechanism itself. Since we are doing in a patient who are hemodynamically unstable, so any type of variation in the patient's condition and as well as the circuit itself, there are several pressure sensors are there. So you have to know at this moment what are the pressure sensors attached to the CRRT machine itself. So if you take into account, you know that there is a arterial line and it is a venous line. Arterial, although the patient will be basically veno-venous, that's why it is called as continuous veno-venous. So the catheter will be in the vein, what we call it as arterial, since we withdraw blood from there. And the arterial line itself is in red, what you can see, and the venous line will be in the blue. And when you are talking about the blood, pointer is there, pen point. Okay. So you can see, follow the pen pointer now. So this is the blood pump, and before that, what you see is the access pressure sensor. And then subsequently, after the blood pump, there is still the filter itself. It is called as filter pressure sensor. Then there is from here, the effluent will come, and that is a effluent pressure sensor. It is there. And along with that, there is a blood leak alarm. And this is a dialysate where you dialysate pump will be there. Then this is the deaeration chamber and the bubble detector. And here you can see the pre-dilution pressure sensor and the post-dilution pressure sensor. This is basically before the pre-dilution is before the filter itself, and the post-dilution is after the filter itself. Just see where the sensors are located. Those are very essential to know, and subsequently we'll see in the dialysis CRRT machine how it is being interpreted. So this is the access pressure sensor where we are drawing blood before the blood pump, filter pressure, then the pre and post dilution pressure sensors, and then the effluent pump pressure sensor. So this is the sensors which are there in the CRRT circuit. So when you are turning on the CRRT circuit, there are indicators and warning signals. You have already known about it. If it is green light, that indicates that the machine is running smoothly. Orange light indicates that there is no urgent alarm. Whereas the red light indicates that there is some issues which needs to be immediately accounted for. So that's why the red alert is more, red signal light is much more important to see, and then subsequently find out what are the solution we can do for that. So what are the various alarms in the CRRT machine? The access pressure alarms, filter pressure alarms, disconnect alarms, air detection chambers and air detection alarms, and blood leak alarm. Besides that, this is the screenshot of the screen of a Baxter Prismaflex machine, which is commonly used. Okay, so you can see here that what are the parameters or what are the interface which you will be encountering here. There is in the left side, those are the parameters like you have to calculate and give a prescription to the patient, that these are the how I have to do the CRRT. Then whether it is executed properly or not, you have to see by the pressure channels, sensors. And these pressure channels which are commonly I have showed you is access sensor, filter pressure sensor, effluent sensors, and the return sensor. Okay. And this is the parameter which is in the right corner. You will see that is CB, the modality by which you are doing the CRRT, whether it is CBBH or CBBHD or CBBH-DF, all are basically set here at the start of the programming of the machine. And this is a interactive touchscreen type of screen which you can manage, and all the parameters are basically can be adjusted by this touchscreen. And this is the machine you are familiar with. And just note down here that all the bags which are there in the CRRT machine of Prismaflex are in the hanging in the weighing scale based, or it is weight based scale. Okay, so here you can see the bags are hung. Whereas in multifiltrate, which are in Fresenius machines, you will see that the filtrate or the effluent will be in the down, whereas all other replacement fluids will be in the up chamber. And this is not a touchscreen, rather it is a knob-based controller is there. So this knob, which is green in color, you can adjust the parameters. Here, what is important to know is basically the replacement fluid. So in the Fresenius multifiltrate, you have to just give how much is the replacement fluid is needed. That will be divided pre-filter and post-filter. Whereas in Baxter, you have to there are dedicated attempt to make it basically whether how much you want to deliver the fluid, replacement fluid in the pre-filter, and how much you want to deliver the fluid in the post-filter. So this is the difference between the two machines. Otherwise, the principle is almost same what I have said earlier. So what are the monitors or the pressure you have to access? One is the access pressure or the inflow pressure. So that is basically sucking the blood by the blood pump at a rate, and that creates a negative pressure. And you have to know that access pressure is always negative. Okay, so it remains between -50 to 200 millimeter of mercury. So then the return pressure, which is the blood which will be pushed to the patient to inside, that is always positive. So this return pressure will be between 50 millimeter of mercury plus to 200 millimeter mercury plus. So these two are required. Basically, the return pressure is required for transmembrane pressure calculation. So there are two things which are required for us. One is pressure drop calculation and transmembrane pressure calculation, where return pressure will be required to know how much is it. So this is a normal pressure range which you can see. This is the access pressure that can be kept between -50 to 200 or -150. Usually the alarm starts happening if the patient is having access pressure more than -250. Similarly, the normal filter pressure will be between 100 to 250, and the effluent pressure will be between +50 to -150, and the return pressure will be +50 to 150. So then these two are very important to know. Is access pressure is always negative and the return pressure has to be always positive. So what are the measured pressures which we will be encountering? The measured pressure are basically filter pressure, and this is the circuit where it will be between blood pump and the filter itself, and after the access pressure sensor itself. And it is a positive pressure. And it is just before the blood which is entering the filter itself. That is the pressure where you will be sensor is placed. It is the highest pressure point in the circuit. A rise of filter pressure may indicate that there can be chance of filter clotting or clogging. And filter pressure is always influenced by transmitter pressure in the outflow pressure. That is, in the down below, in the red area, if the pressure is generated more, that will be reflected in the filter pressure as well. So you have to see all the circuit before, whether there is any clamp is there or not, whether you have not opened the clamp, all those things basically has to be seen before if the filter pressure is high. The effluent pressure is basically the ultrafiltration which is happening in the filter itself, and whatever is taken out from the body itself. The effluent compartment and the filter and the effluent pump, this is the pressure which will be there. It corresponding to the pressure required to generate whatever the target ultrafiltration is there. So what is target ultrafiltration? Target ultrafiltration is basically the amount of replacement fluid what you are giving plus the ultrafiltration what you have set. So that will be seen in the next slides. So it could be positive or negative depending upon the modality of treatment. And during therapy, you can have increased effluent pressure if there is a clogging process is happening in the filter. Pressure tends to be more negative if the clogging, if it happens, then it says that the pressure is more negative to achieve that ultrafiltration itself. And we'll be discussing that in the clotting and clogging differences, how we'll be finding out in that in the subsequent slides. So what are the other calculated pressures? The calculated pressures are basically the filter pressure drop and the transmembrane pressure. And what is the filter pressure drop? The filter pressure drop is the difference between the outflow and the filter pressure. And if it is high, that indicates that there is a chance of clotting of the dialyzer. And if the filter pressure drops, that also indicates that there is a clot, there is clotting of the capillary lumen inside the dialyzer itself, and that obviously will not cause any passage of blood inside, so that will cause drop in the filter itself. What is transmembrane pressure? This transmembrane pressure is basically generated across the membrane, filter membrane. and it reflects a hydrostatic pressure in the blood compartment and oncotic pressure in the blood compartment, beside, along with the effluent compartment, there will be hydrostatic pressure and oncotic pressure. So if the, what is the gradient between the two, that is reflective of the transmembrane pressure. And how it is calculated? The TMP is calculated by filter pressure per return pressure divided by 2 minus the effluent pressure. So if there is any rise in TMP, it could be due to the membrane pore clogging or clotting of the dialyzer. And if there is a high temperature TMP with normal return pressure, that suggests that the dialyzer is trying to clot at that point of time. Sorry, it is clogged. Sorry, return pressure is normal, so it is clogged. High TMP with high return pressure suggests the dialyzer is clotted. We'll be seeing in that in the next slides. So transmembrane pressure alarm, which is a positive pressure alarm, and it is the difference between what I've said, blood and the ultrafiltrate. And TMP alarm usually normally is less than 250 millimeter of mercury. If it is goes above 450, then the TMP alarm starts happening at that point of time. And what are the causes of high TMP? Either it is a clogged filter due to protein deposits in the pores itself, which causes the increased TMP to deliver the ultrafiltration. And if there is a sudden rise in TMP, that could be due to clamped line, and you have to see in the circuit whether the filter or the effluent bag, anything is clamped. And the excessive ultrafiltration rate, if it is there, then also it causes high TMP. If you are using high replacement fluid, that also causes high TMP. So you have to go down in the replacement fluid rate. So this is the same thing which I have shown you. These are the normal figures: access pressure, return pressure, and the filter pressure. And another one is the effluent pressure. So what are the low access pressure alarms? As you saw, when you are trying to extract blood from the vascular venous side itself, it should be in the blood pump is there, so it has to be negative. So if there is a more negative pressure is generated, that indicates that there is some kinking of that catheter or any of the tubing, where you have to see why it is happening. So low access pressure indicates low flow state. So it can happen due to vascular catheter which is aborting the vessel wall, or if there is any clot in the vessel catheter itself, or if there is any kink. And if there is any inappropriate size of catheter, like most often we use a catheter which is appropriate to length and appropriate in size, usually 12.5 French or 13.5 French will be the ideal one to use. If it is less than that, obviously that will cause more less blood flow. And if the let us say in the femoral catheter you are using very short catheter, then it causes abortment of the catheter into the vessel wall, that will cause intermittent blockage and alarms. So you have to see appropriate catheter size and the diameter. And positive access, note here, it is just basically a in the highlighted portion. The positive access pressure implies that the catheter might be in the artery rather than in the vein. So always, if you are having any positive access pressure, inform the nephrologist or the physician who is in over there. So this is how the warning signal comes in the Baxter machine. So you can see here the -250 to 250, it is the set goal, and it has crossed this 250. It is almost minus 19 beyond 250. So that indicates the access pressure is very low, and that indicates there is something has happened in the access circuit itself. So you have to rectify that. So this is the same thing which has been I have spoken about. Then the pressure, high filter pressure. So high filter pressure, usually the alarm starts when there is a pressure more than 250 millimeter of mercury. Is the difference of filter pressure between and the return pressure. And what are the causes? It could be due to clogged filter, or it is due to the clotting of the filter, or there is any clamp in the before the filter, after the filter. So that could be possible, and if there is any excessive replacement fluid rate, then it causes more pressure over that area. So it causes high filter pressure. So those return pressure, if it is high, indicates the return limb. You have to see whether there is any kink or any clamp is there, or if there is any other thing which is pressing the catheter itself. If the filter pressure is high, but there is, then obviously you will see that if the return pressure is low, whereas the filter pressure is high, that indicates that the filter has clotted. So this is the return pressure alarm, where you will see the return pressure is more than 350, which is usually triggered at 250 itself. So you have to see what are the parameters which can be possibly causing the alarm to start. Then coming to the difference between filter clogging and clotting. This is the simplest diagram which I can show you. Here you can see that the pressure drop happens due to the clotting itself, whereas pressure drop doesn't happen in case of clogging. The TMP will either be increased in both the clotting and clogging. Here you can see that the pressure drop, which is basically reflective of where if you are giving any replacement fluid and the any type of like RBCs and other fibrin and other things which are spaced in a relaxed way, that will tell you that it is it is a clogging kind of thing, where the pore size is small in size, whereas transmembrane pressure will be increased in clogging, versus transmembrane pressure will be either normal or increased in case of clotting. What is important to know is pressure drop itself. So this is a chart where you can fix the what is going on with the and troubleshooting itself. If there is a clotting, you can see that the filter pressure is increased and the pressure drop is also increased. That is, the pressure drop has happened more in the clotting. Whereas in clogging, the pressure drop will not happen, but the filter pressure will be increased in both. The transmembrane pressure will be normal in case of clotting, whereas it will be more in case of clogging, since the more negative pressure is created to target the ultrafiltration. So that's why the transmembrane pressure will be increased in that. So whereas the access line, you can see that if there is any increased or more negative access pressure, that indicates there is some kinking or clotting of the catheter at the start of before the blood pump itself. In the return line, the venous pressure will be increased, whereas the filter pressure also will increase. Whereas in case of access line blockage, you will see that the filter pressure will be normal, whereas venous pressure also will be normal. So this is one of the slides which will give you a, if you plot it kind of thing, then you can know what is going on with that machine. And obviously the machines are, current generation machines are very intuitive, and they will interact and with you, and they will find out a solution, what is happening with the, where you have to look for the problem. So what are the ways by which we can prevent clogging? By decreasing the replacement fluid and by changing the HF mode to, or the hemofiltration mode to hemodialysis mode. Since the hemodialysis is basically the diffusive clearance, it doesn't get affected by the small pore size also, whereas hemofiltration requires larger pore size. So that's why if you change the modality, if you want to survive that filter for another few hours kind of thing, you can change the modality from hemodiafiltration or hemofiltration to hemodialysis. And citrate anticoagulation is more frequently used for reducing the clogging of the filter itself. Then coming into the filtration fraction, which is a very important calculative equation which has to be known to you. It usually in the Baxter machine, usually it is it is inside the machine itself. It calculates by itself due to its algorithms. But in Fresenius machine, it is not there. It probably will be required to calculate it. So you have to know what is filtration fraction. Filtration fraction is basically a equation which has been derived from our nephron, basically from the kidney itself, where we use filtration fraction, where the equation is basically GFR divided by blood renal plasma flow. So likewise, the kidney, if you artificial kidney, if you take into account, and the filtration which happens across the membrane is happening. So in that scenario, we can reciprocate the same equation in our CRRT circuit. So here the calculative formula is basically the ultrafiltration, the net ultrafiltration what you are having divided by renal in the plasma flow, the plasma flow itself, that is the filtration fraction. And that is basically a replacement fluid which we were giving. Along with that, the ultrafiltration what you are giving divided by the blood flow, and the how to calculate the plasma flow. Plasma flow is calculated from the hematocrit. So that's why the hematocrit is also required to be fed over there in the machine. And when you calculate the filtration fraction, that is basically essential to know how to increase the longevity of the filter. If the filtration fraction is more, then it causes easy clotting of the filter. So filtration fraction, usually it should be kept below 20%. Acceptable limit is around 25%. And if it is more than 25%, it causes increased chance of filter clotting. So what is the how to reduce the filtration fraction? You must have seen the equation. So the filtration fraction can be reduced either if you reduce the ultrafiltration, or if the replacement fluid can be reduced. But if the patient is requiring that much of replacement fluid and ultrafiltration, then obviously the physician or the nephrologist will not be satisfied with reducing it further down. So in that scenario, you can see that filtration fraction is inversely proportional to the blood flow or the plasma flow. So here, if the plasma flow you will increase, then filtration fraction will go down. So the most often what we do in our clinical practice is start increasing the blood flow rate so that the filtration fraction will be reduced. But if the blood flow rate should be kept in such an amount so that the hemodynamic stability will be maintained. It cannot be increased very high, but it has to be slowly increased by 25 ml per minute or in an hour or so. Then subsequently, so this is the last line which I want to emphasize here again, that these are the problems which you can face and what are the solutions. If you can take this one, I've already shared with the Dr. Ashwin. She will share the PPT slide with you. If you can just remember this slide itself, that will give you much more clearer idea what to do in troubleshooting if there is any clotting or clogging or the problems with the access pressure or the return pressure and the filter pressure. Thank you so much.
Thank you, sir.